Good afternoon, everyone. I'm Kimberly Trelly with PHCA. Thank you so much for joining us for today's webinar, Getting Back to Basics, Maintaining Regulatory Compliance Post-COVID, presented by Kathy Derleth. A few quick updates before we get started today. This webinar is being recorded and will be made available on the PHCA website. The webinar has been approved for 1 continuing education credit for all attendees. For those who provided a NAB number, credits will be uploaded shortly. We'll also share certificates with those in attendance. As we begin today, all attendees will be in listen-only mode. Please feel free to submit your questions via the Q&A icon on your screen, and we'll make sure that we answer as many questions as possible at the end of today's presentation. I'll now turn over today's webinar to Kathy.
Thank you, Kim. Good afternoon, everyone. Hope you're doing well. As we get kicked off today, I am very well aware of how busy each of you are, so we're going to jump right into some really great topics to help us kind of get beyond that COVID era. When I think about this topic, it actually really excited me. Getting back to the basics, how great does that sound? I know that for each of you that have lived each day since March 6th of 2020, it probably feels like a dream. But there are signs that we're returning back to the basics. As CMS revisits and the rules of participation phase 3 changes, it seems like a perfect time for us to come together and review some standard systems or processes. The names of some of these processes or meetings have changed. It might be different from what you call them, but the systematic review and how to get it back into working compliance actually probably is very familiar. So as I get started, who is ready to move on from COVID? Believe me, I feel your pain. It wasn't that long ago that I was a chief nursing officer of a long-term care company, and this arena and field has actually been my world for 41 years. But we all feel that enough is enough. We have to get back to the quality of life for our residents and our staff. As much as we hate it, getting back to our own crazy book of normal, the basics. So today, we're going to discuss how to put post-acute analytics into your day-to-day operations to help allow your nursing team to provide the best aligned care. We're going to have ongoing monitoring and review of the data. That's going to help to guide your QAPI process. And whether you believe it or not, these steps can all be done with really no additional documentation than what you already have in your EHR. So it's our time to begin again, refine our care, and go back to the basics. I'm going to start here. I'd like to talk about for a baseless of what is a clinical decision support system and why are we even talking about it? Well, these support systems help deliver patient safety, care quality improvement tools for healthcare providers, and they use them to help deliver value-based care in the post-acute continuum. It's really like any tool that provides clinicians, administrative staff, patients, or a care team information that's targeted to a specific person or situation. That is called a clinical decision support system. The goal of similar systems is to reduce clinical variation, duplicate testing. You try to identify patients by risk and avoid complications that end up resulting in expensive hospital readmissions. These are the top priorities right now for providers in the modern regulatory and reimbursement environment. So it's taking and harnessing the hidden insights of big data to help achieve this one goal. Ultimately, CMS calls clinical decision support systems as getting the right information, such as evidence-based guidance or response to a clinical need, to the right people, meaning your entire care team, whether that's the patient, hospital, doctor, or nurses, through the right channels, which means mobile device, EHR, or a patient portal, and in the right interventional formats, So you can develop flow sets, order sets, dashboards, patient lists to give you that information quick and timely, but collaborative across the continuum. It's making sure that we are looking at the same information for decision-making or action. So why is data analytics in the conversation? Well, when talking about long-term care, there is a lot of discussion on how best to coordinate that care among providers. Analytics will help you to be more specific about what care a patient needs when we're all operating from that same set of information and goals for care. So when life or death treatments are being made, it's vital for all key players to have the same priorities. You know, healthcare recognizes that there's an integration of many sources of medical information, various testing, various doctors, various subspecialties, but the standardization is really of utmost priority so that you can pool and collect this data to provide actionable, prioritized information to the user end. Moving to a standard primary health record, as you hear about in the news now, really supports the advancement towards this goal. You know, life after COVID, it's real, it can be. We are returning to some sort of normal. But during the pandemic, you know, CMS had to use a whole variety of emergency waivers. They made special regulations and guidance. They're trying to offer the providers the flexibility needed to respond to the pandemic. But in certain cases, these flexibilities went ahead and suspended some of the traditional requirements and things that we had, and those are getting ready to change. So CMS is now taking steps to phase out certain flexibilities that are generally no longer needed. And we're going to reestablish back certain minimum standards for those individuals residing in skilled nursing homes. By them ending some of these waivers, they're actually helping that nursing home to redirect your efforts back to meeting the regulatory requirements aimed at ensuring each resident's physical, mental, and psychosocial needs. You know, annual surveys are back on the books for many nursing homes. We know that there was a lapse there for a while. This slide helps to demonstrate that the state survey agencies are getting through and checking off those backlogs from the last 24 months. The trends you see here are from January 2022 to present. And please note some of the common areas of the non-compliance tags. You know, patient and resident health and safety are always going to be top priorities for CMS. And the recent actions focus on ensuring that every nursing home resident is cared for in a safe, high-quality environment. The recent on-site surveys findings have provided insight into some issues that are really focused on the actual resident care that go beyond infection control. And that's things like they highlighted resident weight loss, depression, pressure ulcers, and that's why we see so many in that F684 tag under quality of care. But they also lack certain minimum standards, such as training for nurse aides. They feel that some of this lack of training and not being able to focus during the COVID has contributed perhaps to some of these additional tag issues. By ending some of those waivers, CMS is helping nursing homes to get back to meeting the regulatory requirements aimed at making sure that physical, mental, and psychosocial need is being met. While disrupting all aspects of life around the world, the COVID-19 pandemic had an enormous, large impact on our care delivery system, right? With this in this country and with long-term care facilities really disproportionately being impacted by the pandemic. The flow of the hospitals and the encourage to set up units, specialty units, COVID units, and having that influx of patients. But we know we have more to focus on than just COVID. The return to the phase 3 rules of participation changes that are going into effect end of October brings resident care forward and quality of life back into focus. It's refreshing and revisiting all areas of care that is important. I believe it starts with some core foundational principles. And today I'm going to review some of the structured processes that can help you improve quality of care and maintain that regulatory compliance. Foundations are what we build upon. They are the basis for maintaining the structure of any organization. Why are we discussing foundations of our care? Well, first, we must understand that it's the current state facing healthcare delivery systems, and there is little room for margin of error with our current times. We must always give the best quality of care, and the regulations help guide us to monitor that we are indeed providing it. There's a new push towards value-based care, which is a system of care delivery where your financial reward is tied to improved patient outcomes. And that's all equally measured against what the cost of that care is. So from a policy and payment perspective, there's a strong financial reward is now tied to the patient outcome. From the clinical and operational perspective, we need strong communication and process protocols, good staff training, and capable leadership that will execute against change management. It's really about being able to assess our needs, target the correct interventions to the right person at the right time, regardless of what that is. So, how strong do you think your foundation is? Is it built on solid ground with system, process, and an effective QAPI? Are your leaders aligned to your goals? You need a strong clinical focus, but yet maintain the resident at the center of all our care and thoughts. We have many people depending on the fact that we must have a strong foundational base, one that can withstand staffing challenges, financial value-based purchasing and ACOs, and of course, the intense regulatory focus. As I thought about a foundation, I recalled learning that no foundation is strong enough to withstand if you have an improper or weak cornerstone. Everything else gets set firmly based on this piece. When I think of it in reference to long-term care, our cornerstone must be strong and able to withstand changes in the surrounding weather, but it also sets the tone and leads in each piece thereafter. Leadership is this cornerstone. You need to have consistency, stay connected to your staff, curious about what else is in the field and business, and conscientious enough to lead and guide your team through everyday change. You know, leadership is going to define the core of your facility or company, but let's not confuse this trait, however, with managing. You know, I think we've all heard the saying, people don't just leave their job or position, but they leave their managers. There's actually a Gallup poll of more than 1 million employed US workers that concluded that the #1 reason people quit their jobs is a bad boss or immediate supervisor. 75% of workers who voluntarily left their jobs did so because of their bosses and not the position itself. With staffing in long-term care the way it is, we cannot risk anyone walking out that door. We need more leaders. If we've learned anything the last couple of years is that change is inevitable and that the goals change from day to day. So leading means to be in front of the navigation, forging the path with new ideas, being inspirational and ethical while meeting the needs of our customers. And our customers include residents, family, and staff. Leading through change is difficult. It's one of the toughest things for leaders. In long-term care, changes happen quickly, and it's our job to prepare the staff and ensure that they know we are there with them to navigate through it. As you think of the systems we're going to cover, I want you to think of them in kind of 3 stages: pre-implementation, implementation, and finally, sustainability of these systems. You know, when you look at each of these stages, there's many different processes, or if you study leadership a lot, domains, so to speak, that are considered. There's the governance and leadership. You've got policy and your physical environment and layout. How do you engage with your staff? You do need to do ongoing assessment and training for them as well, and workforce development. But the final key is to monitor and sustain progress of anything you implement through quality assurance. So, getting your team ready for change is a priority. You know, normally when talking with nursing homes and I say we're going to review 4-step plans, automatically some roll their eyes or sigh. So go ahead, take a deep breath. It feels good, doesn't it? Today, I'm going to highlight a couple of 4-step plans and use them to help you improve your survey outcomes and ultimately become the provider of choice. We're going to call this the A plan. Our first A is align. Align your foundational systems to be able to monitor clinical system and quality outcomes. If you allow standard care practices, this helps create foundational systems that can be brought into daily clinical operations meetings, and it helps you to achieve and sustain compliance. Often these are things based upon diagnosis or specific clinical condition. Assign. I like this one because with staff being at a premium right now, we can assign the optimal level of care and focus through QAPI to support process improvement, but at the same time, you're putting the best skilled services by the person who is operating at the top of their license. RNs are at a premium. We can designate based upon the care and levels within the facility where that license is best used. And encourage, as we mentioned earlier, leadership change, staff development, and workforce development. Last but certainly not least, adherence to regulatory standards and foundational systems. And that structure helps us to impact risk mitigation. So that's plan A. And that I did that to just put and think of it in the context of those words. Our second 4-step plan is where we're going to focus a little bit more in depth today. It is rebuilding your foundation through the P's. Once the cornerstone of leadership is in place, it's time to tackle the job at hand, getting back to the basics of care. This overarching plan can be used by either new leaders or seasoned leaders. And I'm going to break it down into 4 quicker overarching actionable items. Prepare and practice, psych your team, plan and pace your team, and then of course, as always, complete your plan of correction. Here's where we're going to spend the majority of our time today, and we're going to be talking about what are the essential building blocks for success within the long-term care. On this side, you'll see what I label them. These core meetings or processes that if we complete them consistently and with live data from your EHR, you can make a stronger foundational care delivery system. So let's just read them. We've got clinical meeting, a grand rounds process, care plan meeting, hospital readmission reviews, infection control meeting, skilled care meeting, staff and training competency, as well as our favorite QAPI monitoring. So I am going to throw and want you to think about your facility right now. In the context of your facility, ask yourself this question. How many of those systems that I just named do you believe you have in play? None, 1 to 3, 4 to 6, 6 to 8, or all of them? They are key vital components to clinical operation and quality care. So think about that, and then we're going to review, if there's only a few that you were able to answer, we're going to give you some of the key core components of how to improve those meetings in your facility and get back to the basics. Clinical meeting. Clinical meeting is, to me, the anchor that keeps the ship going in play. It's got us, we're on course. We know where we are. We don't want to veer off to the right or left. It is the meeting that, if completed each and every day, and yes, I do mean even on the weekend, it will provide you the best line of sight into your residents and allow the earliest and most comprehensive approach for care. It is the meeting that focuses on care delivery and communication across business lines and multiple service lines. It's the best way to start each day. A well-managed clinical meeting is multidisciplined with concise assignment and follow-up. So not just assigning, but ensuring that that follow-up occurs, as well as using it as a broad-based communication meeting that sets the course for care each day. Utilizing live data analytics can eliminate hours of review and prep time on the info that is already, and help you to already be acting upon some of this data during your clinical meeting instead of that time gathering it. Analytic solutions can identify risk, subtle changes. They can monitor if you put into place some set standards of care, like CHF patients, we weigh them every day. We get labs every this day. Identify as well and monitor infection outbreaks. The right solutions scan hundreds of structured and non-structured pieces of the medical record, and it helps to already prioritize what are the most important and urgent items for follow-up. And here you can see just a few of the items that I'm speaking of. But now let's look at what could that daily agenda hold. Again, these are some of the key areas and items in that meeting that can be assigned for follow-up. This extensive list are just things that can efficiently be reviewed during a clinical meeting. And the best process uses the time during the meeting to determine and assess, action and interventions versus hours to collect and review the documentation to capture priority items. So I come from the old days where we printed off, all the progress notes for the last 24 hours before my clinical meeting. But in a large facility, that sometimes was 40, 50 pages of notes. Some of those were standard notes that maybe I didn't need to be reading at that moment. But with a solution like this, assignment and priority, you can now see those highlighted individuals who are having changes and begin to make the action steps much timelier for those residents. So let's take a look and compare an older traditional clinical meeting versus one that might utilize live data. Here you're going to see on the screen, on the left is the older manual process. So as we said, we show in this timeline approximately, for a good average size facility, 120 to, 130, it could take up to 2 hours to be reviewing all of the progress notes or various components within the chart, making your notes for follow-up, bringing that to the meeting, and actually getting a chance to go over next steps. So that could be from 8 to 10, 10:30 in the morning. You're not getting out to follow up on that care for approximately 2.5 hours after you've identified it, even in the note, no less that it could have happened during the night shift the night before. By the time you get to those residents, it is possible that the change in condition has escalated to the point that that resident is already going out to the hospital. Whereas on the right side, by accessing a live data analytics process or solution, because of the way it's able to pull in the information, identify high risk, start giving you those key subtle resident changes, you're able to be back out on that unit following up on those priority residents much sooner, so that hopefully you can prevent that readmission to the hospital, but more importantly, you're giving timely quality care to your resident. Our second process that I'd like to review is called grand rounds. And I will say, I've heard this used in a variety of ways and terms as well, but this is a perfect meeting that's used to coordinate your team. In a grand rounds meeting, it's a very person-centered, resident-centered process that focuses on identification and opportunity for improvement. It's a big, and it should be, a collaborative interdisciplinary approach to drive quality. You know, there are routine reviews, systemic reviews, and when this meeting is scheduled is based upon the MDS or admission calendar. And it's usually set 2 to 3 weeks prior to the ARD for best results, or within 48 hours of a new admission. You want to identify risk areas doing grand rounds, and you're going to develop programs that are tailored to the individual. What do I mean by that? Well, we're seeing, based on the documentation, that they are having more incontinence episodes. We're able to, as a team, review that quickly, kind of highlight and decide on an incontinence toileting plan that would be fitting and specific to the resident. Perhaps it's pain management. They're having breakthrough pain, restorative, or if therapy intervention may be needed. It's a perfect meeting to identify opportunities from a decline of care. It's also a proactive approach to identify those area of risk and really focus on the function of what the resident is doing. Use the grand rounds process to psych up your team, our second P. Why do I say that? Well, you know, it's a perfect opportunity to engage with your team. Through discussion with staff, you'll probably be able to quickly identify change in condition. They work with them each and every day. They know them best. They can tell when someone's having an off day. By using standard tools like the stop and watch or the S-bar, that helps that flow of communication regarding a change and help plan the next step clinical pathway. You know, you can decide on standard order alerts, interventions, looking at their documentation. You can set up risk assessments based upon high-risk diseases like CHF, COPD, and sepsis. You know, it's all to help prioritize with your team who they should be focusing on as a priority of care of those who may be having some changes or decline in condition. And the CNA needs to be aware as well as to what that data and information is telling you. So this is the perfect opportunity. The tools and processes during grand rounds also should focus and recognize those who may need advanced care planning. And we're going to talk about that more in a couple of minutes, so I won't go into too much of it here. We talked about standard clinical pathways like ANDA and Interact 4.5. They are often diagnosis-driven, and it lets the whole IDT team know what is that plan of care. So does this resident need education on diabetes and their diet, or CHF, they don't have salt, kidney, patient teaching that needs to be done and completed. And then more importantly, how to monitor, like, are we making an impact? We talked earlier about working at the top of the license. So during this meeting, we're able to prioritize if I have too many extensive support and lift and ADL needs on one particular unit. Do I need to reallocate my resources based upon that unit? And last but not least, talking about, and we'll mention in a moment, identifying residents that require late loss ADL support. And by doing this process with the whole team, you're able to recognize illogical coding errors. You know, we spoke earlier of leadership traits, and this process meets multiple areas of leadership. It's helping you engage with residents and staff on their care. In other words, you're having direct on the floor engagement with them. You're asking them, what do you do for this person? Okay, well, does that meet the documentation that you're putting in? It's educational opportunity. Reviewing that documentation and understand what is the care that they're documenting versus what's actually being given. It helps you have eyes to monitor for changes. It lets your team know that you inspect what you expect. And there is an ability to recognize your team for the care that they provide. Celebrate with them the great care they're providing. Well, really having an IDT meeting, you know, you're always identifying and mitigating risk, but you're also care planning for the best course for the resident. The grand round process facilitates collaboration across all disciplines and members of your team. So here, what are some of the benefits from grand rounds? They're vast. I'm just going to highlight a few quickly. You know, you have the quality of care that obviously is going to be improved because you're meeting the resident at his need. You've got quality of life and engagement that you're able to monitor, interact with, and support. It meets regulatory standards and compliance. It puts eyes on that unit for safety, environmental, as well as resident patient concern. And it is resident-centered care at its best. There is the outfit as well, the effect on your 5-star and many of your quality measures. Phase 3 is coming, and there's a huge focus on quality of life, behavior health, additional services, trauma-informed care. This is the perfect meeting to ensure you're meeting those needs. We just spoke a minute ago about that ultimately grand rounds leads to care plan meeting. So a return to good, comprehensive, interactive care plan meetings is vital to steer the ship of patient care. It's where we plot the specific course based on the individual resident's risk and needs for care. Again, care plan meeting can be summed up as working together with one or more members of the healthcare team. Each person makes a unique contribution towards achieving a common goal with that resident at the center. This meeting must include the resident, family member, and all members of the care delivery team. Once again, we talked about clinical decision support systems. You're looking at the same data and risk identifiers. Those support the current and future course of care for a resident. You know, the right data analytics process streamlines this and highlights the changes that are in a resident. It's working with an interactive plan, and it's kind of like, it's going to give that caregiver a map of what are the things that I need to make sure are done to make sure I'm providing the best care for this specific resident. Where do they want to get to? Is that reasonable? And how do I help them do it? Make sure you're setting clear and concise goals, and more importantly, celebrate achievements. I love seeing now often on Facebook facilities that people are, you know, being able to go beyond their care. They're meeting therapy. They're going home when they've been there for extended periods. It's exciting to see people be able to reach a goal, and it gives them something to work for. While collaborating with the family and the resident, you know, make sure you begin in this meeting if there is any needed end of life or advanced care planning discussions. So let's talk a little about advanced care planning. Advanced care planning is an ongoing conversation, right, that involves shared decision-making to clarify and document through an advanced directive. So that's the tool where we gather this information. And what are we evaluating? We're getting an individual's wishes, preference, and goals regarding future medical care. So this process is really critically important to make sure that residents are going to receive the care that they want. should they in the future maybe lose the ability or the capacity to be able to really evaluate and make decisions on that. We want to make sure to help them document now. It enables patients and families, are informed, the doctor is involved, your care team is involved. It just really provides support that otherwise might not be available. Ultimately, the vast majority of any of us want to die at home with family present if possible. We definitely want to have our pain and symptoms controlled. We want our wishes known and honored. We'd like to be treated as the person we are with appropriate psychosocial and spiritual support. And we want to know that as we progress through our disease and end of life, that friends and family members that are important to us will also be cared for and that they will have the support that they need. As healthcare professionals, we play a very important role in advanced care planning. So as we continue to monitor care and think about our care, a key step to success is establishing time to review your hospitalizations. And sometimes this is for the good and bad, any opportunities that we might have for care that we've provided. Care coordination now is becoming more important as ever, as I mentioned, across care continuums, ACOs, value-based purchasing, making sure that we're using the right level of care when we need to. So how do you break that cycle of readmissions if you see that you have a lot of individuals that are going back to the hospital? Well, we already talked advanced care planning, making sure that they want to go back to the hospital. But now I'm also going to talk about using some data analytic metrics to help you manage and review your hospitalizations. One of our advisory board members had stated it like this: information sharing provides both the acute hospital and post-acute care, data and information all at the same time. And it helps us to access data, analyze data, make sure we're all working from the same place, and then more importantly, implement systems to make sure we're getting some quality-driven metrics. Recent changes with the hospitals, they have to give a patient choice when they're going from a hospital to a nursing home. So you need to understand 5-star and what people are seeing and what is being shared with them so that you may speak to potential customers. They often also look at the quality measures based upon hospital transfer, which is successful transfer back to the community. You've got hospital care. The hospital's goal is to get them back into the community where they can continue to manage their care through PCC and PCP and supportive services. So, work within your healthcare continuum to try to identify and implement programs that may meet a community need. We talked about with controlling readmissions back to the hospital is some risk stratification. When we were in clinical meeting, we want to know those residents that are at highest risk for going back to the hospital. And in the context of, are they having subtle changes, vital signs, infection risks, what kind of other things are going on with them, in the context as well with this additional layer of readmission risk. So another part of the hospitalization meeting is risk stratification. It's understanding who's at high risk for readmission and why does it even matter. Risk stratification, if I can explain it, helps providers identify and direct the right level of care and services for this distinct group of patients. It's kind of like case management approach. It stratifies people by high, moderate, or low risk. You're able to deploy your top level resource around your high risk patient. What are the things that go into the components of, a risk tool, any sort of risk stratification tool? Even if you did not have an analytic solution, thinking about that resident's changing clinical condition. You want to know how many times have they gone back and forth to the hospital. You want to know how long they've been in your facility. Why does that matter? Well, we know that statistics will show that anyone that's been in the facility less than 72 hours is at the greatest risk for going back and forth to the hospital. And that's for various reasons, and we're going to talk about a few of those in a minute. But you also have high-risk diagnoses. So CMS has identified as well, that the majority of patients from long-term care that go back to the hospital are often people with CHF, COPD, sepsis, infection, COVID, so end-stage renal disease. Some of those high-risk conditions make individuals very at risk for going back to the hospital. Use some sort of tool or just these 4 main components, and we put them in the CARD, clinical alerts, admission recency, readmission history, and diagnosis score, and try to evaluate and critically think about to manage someone's care. The best practice for a weekly rehospitalization meeting helps you identify these individuals that went to the hospital. Were they a high risk? What could we have done better or different? Use the meeting to look at trends, days of the week. What day did they discharge from the hospital, perhaps? Did you have a large practice where the doctor covering didn't know the patient as well? Do a very detailed QAPI review of transfer. Then you use whatever comes out of this weekly rehospitalization meeting for your goals of education and change in care delivery for the best management of your patients. Poor handoffs have really been among one of the top reasons for serious patient consequences. Researchers and educators have taken a look at this. So there's lots of research out there as I was looking into it. They're really looking to try to figure out and increase system safety and resilience. So there's 6 items to focus on. Here's what we know. When a patient moves between any care setting, there's a couple things to really take into mind, and some readmission prevention tactics are here. Communicate the status and care plan for each patient, nurse to nurse, right? Specify tasks that are going to be needed at the time that person went. So if it's an IV med's going to need to be hung an hour after they're transferred, we want to know that. Anticipate questions and problems likely to arise. Streamline the patient care task load. So is there nurses that can assist and support for the admission? Can someone else put in the orders? Who gets the assessment? How to make sure that that's flowing smoothly. Prioritizing problems by acuity. So again, looking at the whole package of that resident that's coming in, and ensuring accurate documentation. We mentioned earlier already that not only do you have communication with your team, you need that 48-hour care plan meeting, but you also, upon admission, should have kind of an onboarding meeting with that patient, family, and care team. You're looking at those discharge dates, you're figuring a date, you're looking at goals, and you're letting them know the course and plan for care. In hospital meetings, we've talked already about readmission risk. We've talked about smooth transition to care, but that QAPI review is vital. And now hospitals as well as payer systems are often having these one-on-one reviews with your facility. Be honest and learn where a missed opportunity was and take the action to prevent again. Through these calls, you also have partnerships, right? Collaboration on care, shared outcome, getting familiar. They get faith in what you and your team are able to provide. That partnership also may meet future mutual placement needs. So when you have that really tough readmission that needs to go back to the hospital, behavior support services, placement difficulties, they want to know as well and have faith that they can place a resident with you. In that meeting, you're also going to look at those high-risk diagnoses. And why is that? You've got to make sure you're better at intervening to prevent them, but you also need standard care strategies to really address these top 5 high readmission diagnoses. You know, be willing at the end of a hospital meeting that you have been honest in your evaluation of your practice. We're going to move over a little bit. I know we said beyond COVID, but there is more related to infection prevention, monitoring, and surveillance than just COVID. So despite the fact that we want to move beyond it, we have to recognize that infections are still prevalent in our environment. So besides being, a regulatory requirement, we must perform ongoing infection preventions and surveillance. You know, select a time and a meeting to review your infection control risk data, your outbreaks, antibiotics, and your vaccine use. You still have to set aside time for this meeting. You know, one positive that came out of the pandemic has been an improvement in the relationship between your infection preventionist and the clinical staff. They really had to begin to rely on each other. So at this point in time, we now need to also use that infection preventionist to really start working with administration on updating healthcare teams on what else is out there beside COVID, working with facility administration on incident commands, and to take the best practice lessons that we learned from COVID and continue to engage. So having an infection control strategy can be done with daily consistent engagement. Whether you're using those standard communication tools, Stop and Watch, SBAR, or an analytic solution that's giving you infection risk, vital sign changes. You have criteria for when you're going to start antibiotics, monitoring infection rates and whether healthcare acquired, community acquired. You know, the biggest key that I would say for this meeting is making sure that you're getting the right data into the hands of your infection preventionists. You know, there are solutions out there that can automate the 7 regulatory demands for infection prevention. If you streamline this process, your IPC could spend more time on the unit training, observing care, teaching, and analyzing the data instead of trying to figure out how to track all the required info in multiple spreadsheets and forms. It's putting the information into your IP's hands. I know I'm trying to, it sounds pretty simple, and then I'm, trying to make it easy and light. But if we set aside time even once a week to review data, QAPI trends, and implement a few key proactive items, you will have a positive outcome. Bring that data and information from that meeting to your staff huddles. Let your staff learn to know what they need to be looked for keywords and vital sign changes that are really specific to individual residents. Last but not least, you've got to have this meeting anyway. You have to include members of the community. So remember as well that your surveillance data must be readily available and shared with your committee, your residents, families, QAPI team, and of course, part of the survey process. The skilled care meeting is our next meeting that's got a variety of terms, but the goal's the same: skilled care and case mix. Make sure you're providing the appropriate level of care with the optimal benefit to improve a resident's level of care, whether that is PDPM, IPA, CMI indicators. You know, the best performing facilities perform a 52-week approach, because it's kind of like this. They're focusing on CMI window only when the window opens isn't going to bring the result that you want. It's kind of like cramming for a test, the night before and thinking you're going to get the optimal result. We've got to have this monitoring on an ongoing Q-week process. Recognizing items for PDPM captures improved lately, right? We're able to learn a little bit more on how to do that. the goal from this meeting is to review, review, review. You know, you want to audit your medical records and monitor your process. You know, this is similar to like a level of review process that accounting firms do. They always are auditing. And why is that? Because the more levels of review into your medical record, the more your process will lead to the highest level of accuracy. The key elements to look at here, you know, whether it's PDPM, case mix, first, encourage open communication between nursing, therapy, and MDS. Ensure clinically appropriate Part B, accurate ADL coding, behavior documentation, and that your therapy usage is appropriate. You can avoid case mix audits. Just really pay attention to the RAI manual and what needs to be completed, capturing the data from orders, immunizations, visits, you know, BMI, tracking the baseline and current height and weight is critical, and we know that that often gets missed. For accurate coding, that you get not just regulatory compliance, but you get accurate reimbursement. So how do we teach staff their key? They impact Medicare, Medicaid, insurance. It impacts our quality measures. Like we said in a grand round, read it, comment, ask them about it. Make sure they know that their documentation really matters. We're going to move into survey management and preparation along with QAPI, and we'll be wrapping up momentarily. Let's speak about the QAPI component that's so many ways to maintain regulatory compliance. You know, if you maintain these basic foundational systems, that is your formal survey prep. You don't need a mock survey when you're going into your window. It's important to have an ongoing focused plan for quality. There will be shortcomings, you'll recognize them, you'll work some plans and set new goals, but the most important piece is to keep monitoring for success. And in case you aren't aware, we have the ability to follow the exact process surveyors will follow. And I have it here in the slide for you, the link, where you can get it and where you can go for the download. That 6-step process, you know, it's worked into offsite preparation, facility entrance, how they pool their patients, sample selection, investigation, and determining compliance. Of course, we'll talk through the QA about your plan of correction and revisit. But of course, after they leave, the regulatory work's just beginning. Don't wait for your 2567. You know, you should already be starting your baseline audits, and they should be underway before you get your 2567. The key is, if you maintain these baseline foundational meetings, your audit review process from surveys is already in place, so no extra work is needed. You're able to identify residents at risk, train your staff, plot what changes might need to be made to your system, and add that final step of evaluation. This slide shows these are just basic key pieces of a proactive survey management plan. It can be maintained via systems that, you know, we talked about that are going to incorporate these items. Good Solution can give you info in real time to allow for best management and prevention of citation. This does not have to be time consuming. You know, the right technology provides the right information at the right time to reduce administrative burden on your team, not add more extra audits and processes and training. I'm including here as well a real key piece as we move forward past COVID. Phase 2, you know, really focused on staff competency and training. So it's not just for POC activities. You've got staff training and competency. We have to be knowledgeable about the type of residents we're caring for and ensure our staff are trained. You know, new hires have to have training on abuse, neglect, and their job as mandatory reporters. You know, it's very important when we're working with adult learners is for them to understand how what we're training them on is meaningful for what they do every day. I always say as well, within the context of the resident, since they are our priority. The seventh step that I mentioned earlier related to the survey process is quality assurance and process improvement. If you haven't heard, I've talked about this throughout the presentation. This seventh step, is to, always be planning correction. With over 900 tags or deficiency potential, we're not always going to be able to keep it together. But having a plan to institute and evaluate basic systems and processes is going to be your key to success. I think about this as like the cherry on top of the sundae. All other systems are basically, essentially, subsets of this process. They are bringing the data analysis forth for analyzation. It's, QA is vital when you're caring for people. We all want and deserve the best quality care possible. In QAPI, if you can go through many documents from CMS, it's using data to track and trend, analyze the data, and then develop a focused plan with metrics for success. Make sure too that your medical director, as well as members of your care team, are integrated voice and partners. It's the best way to engage everyone in success. Direct caregivers give very key insight, and it provides them a sense of ownership and inclusion that we discussed at the beginning about leadership. The climb of the steps is basic foundational systems now. Here is complete. This is the difference that those live data analytics can make. Data analysis can be time consuming, but if some of these key functions are able to be automatically prioritized and reported, your time instead is spent on caring for the patient and developing plans to continue to improve your quality. They help you optimize compliance and manage your QMs. You can risk stratify patients to prevent declines in care or hospitalizations. And then you can make sure you're receiving the reimbursement that represents and reflects the care you're providing. We're going to close, but I want to leave this slide. We're taught there are basics to survival. Nursing homes are facing the toughest times post-COVID. Staff shortages, declining census due to staffing limitations. You've got new and highly demanding regulatory requirements. And then by just implementing some of these basic systems that I've reviewed today, it can give you a chance to remain a viable and thriving program. I wish you all great success, as we need each of you to continue to care for those who need it most. Thank you, Kim and PHCA, for the time that you gave me today, and I thank each of you for what you do each and every day.
Thank you so much, Kathy. At this time, we'll open up things for Q&A. If anyone happens to have any questions, please submit those using the Q&A icon at the bottom of your screen. And I'll just hold a moment or two to see if anything comes through. As a reminder, if you have any questions that come up after today's session, please feel free to reach out to myself or Kathy. And Kathy, again, thanks for sharing this important information today. Thank you all for joining. Everyone have a good rest of your day.
Great. Have a great day, everyone. Thank you.
Bye.